Hello, welcome to our YouTube channel. I'm Dr. Yusafit. Today we will proceed to our exit exam part 9 discussion. So let's go to the question. So a 60-year female patient presented with sudden onset right upper quadrant pain accompanied by rigor, fever, and vomiting. On examination, the patient was in agony with blood pressure of 160. Pulse rate of 96. She had mild icterus of the sclera and right upper quadrant tenderness. The most likely diagnosis of this case would be A. Acute cholecystitis, B. Acute pancreatitis, C. Ascending cholangitis, D. Perforated peptic ulcer disease, E. Intestinal obstruction. Try to answer this question. You can pause the video. So the answer would be if you say C, you are correct. So ascending cholangitis is the answer. So let's discuss why ascending cholangitis is an answer for this particular patient. So cholangitis is a life-threatening emergency caused by obstruction of common bile duct with gallstone that is escaped from gallbladder. Symptoms include jaundice, fever, right upper quadrant pain, altered mental status, hypotension, or shock. So we do have a clinical criteria to diagnose cholangitis. One is being Charcot triad, as the name indicates. It has three signs and symptoms which suggestive of ascending cholangitis. One is fever, and the other is jaundice. Jaundice means it's a yellowish discoloration of the skin, sclera, and mucous membrane, and as other term for jaundice being icterus. For this particular patient, for example, it indicates that there is icterus sclera, that means jaundice. So right upper quadrant pain. So if you add a sign of septic shock like hypotension and altered mental status, so in addition to the Charcot triad, we call it the Raynaud pentoid, and it's suggestive of severe cholangitis with septic shock. So Charcot triad plus hypotension plus altered mental status like coma, confusion, that is called Raynaud pentoid. And if you found those, it is very suggestive of ascending cholangitis. So let's see the picture or the anatomy of the biliary system. So ascending cholangitis means it's commonly caused by the stone that is present in this area, this common bile duct, So the common bile duct, it is this from here to here. So so in the passage of this, if there is obstruction of the flow of the bile with a stone, for example, with a stone, the flow of the bile is obstructed, so there would be stasis here. For example, if it is obstructed here, so the bile come as it is conjugated, and there is stasis. So that stasis is a, a good media for the bacteria. So obstruction can result in infection. That is what we call it acute ascending cholangitis. If you see acute cholecystitis, the obstruction is not in the common bile duct, but the obstruction be here in cystic duct. The stone may obstruct here in cystic duct. So the bile will not flow through the from the gallbladder itself. So the inflammation is limited to the gallbladder. So when you think of about the jaundice, there is no jaundice in acute cholecystitis. It's very rare. There is a condition called Miri syndrome that is very rare. In that time, the patient may present with jaundice. Otherwise, jaundice is very rare in acute cholecystitis, and in common bile duct, as it block the flow of the bile in the common bile duct passage, so the patient commonly present with jaundice or yellowish discoloration of skin, mucous membrane, and the eye. So that is typical presentation for common bile duct, but in acute cholecystitis, we will not see the jaundice. So in that particular patient, the patient present with ectaris sclera, that is jaundice. So the diagnosis go more of for the common bile duct, and the jaundice that is, or the bilirubin that would be high in common bile duct is it direct or indirect? Is it conjugated or unconjugated? It is direct. It is direct, or the conjugated bilirubin will be high because there is no problem with the conjugation. The liver is fine. There is cholestasis, there is stasis of the bile flow, but the liver is fine. It can conjugate and release, but there is obstruction here. So the answer will go for common bile duct. If we consider acute pancreatitis, the presentation for acute pancreatitis is an epigastric pain that will radiate to the back and also sometimes to the shoulder. But the risk factor being stone can be the risk factor, uh, but in patients with alcoholic, the risk would be high. Acute pancreatitis would be high in alcoholic patients. And the other typical presentation for this group of patients in acute pancreatitis is that in the amylase and lipase would be very high. And the patient should have to tell us about the lab finding, especially the amylase and lipase elevation. It may be around 3 times higher than the normal value. So, acute pancreatitis would not be an answer for this. Intestinal obstruction, no, it's clear. So there is no jaundice, and intestinal obstruction, be it in small bowel. For example, if you take small bowel obstruction, the patient presented with vomiting and also abdominal distension. Vomiting, abdominal distension, but there is no jaundice. Jaundice is not a presentation for intestinal obstruction. So the answer is definitely the ascending cholangitis. If you think of the perforated peptic ulcer disease, those patients particularly present with burning epigastric pain, and the pain would be associated with meal. For example, if it is the peptic ulcer, when you even talk about peptic ulcer, there is two type of ulcer. That is gastric ulcer, which is in the stomach, and also duodenal ulcer, So when you talk about gastric ulcer, it's worsened with meal. In the patient, it's the pain, the burning sensation of the pain, or the vomiting will be severe. When you talk about the duodenal ulcer, it's improved with meal. When the patient eats, the patient will the pain will improve. It got better, and when the patient doesn't eat, though the pain will come in the duodenal ulcer. So, in the classic presentation would be epigastric pain that is associated with meal, and also the patient may have history of this burning epigastric pain with bloating and other like early satiety. So that may be the typical presentation. Jaundice is not a presentation for this, and that we can rule out it. So the answer would be ascending cholangitis. Please, this is very high yield point. You should have to read well and see this video carefully. So let's go to the question 2. So 40-year-old woman had a subtotal thyroidectomy. 4 hours later, she started to complain of difficulty of breathing. So on examination, she had a stridor and markedly swollen, tense neck wound. And the first step in management of this patient would be A, intranasal oxygen application, B, perform a tracheostomy, and C, insert NG tube, D, open the wound to evacuate the hematoma, and E, aspirate the hematoma with needle. So again, please pause the video and answer this question. So the answer will be, if you say D, you are correct. Opening the wound to evacuate the hematoma uh, is the first step in management of this patient. So what does this patient particularly presented? It presented with difficulty of breathing and stridor. So this patient have definitely sign and symptom of upper airway obstruction. Upper airway obstruction. So this patient has difficulty of breathing, which is distress, and in addition to this, the patient has a stridor. You know this stridor. So stridor is one of the clinical finding which suggests patient is having upper airway obstruction. So especially we say it is inspiratory stridor. So inspiratory stridor is a sign that suggests upper airway obstruction. And also this patient had hematoma after surgery was one of the complication of thyroidectomies. After surgery, the patient may present with hematoma. That is a collection of blood. There may be a bleeding artery, vein, or capillary, and the collection of that blood, we call it hematoma. So it's one of the bad complication of the surgery of the thyroid. So markedly swollen, tense wound, neck wound. After surgery, you may think of hematoma, and this is life-threatening. It will obstruct the airway, and the patient may end up dying. So the first step is to alleviate this obstruction. How do you alleviate? You should have to open the wound, if that is possible. And based on the presentation, if it is very severe, the obstruction is severe, and even you can open it in the bedside, and then going to the surgical OR to further uh, make it good. So opening the wound to evacuate the hematoma is essential step to save the life of this patient. So it's a management of neck hematoma after thyroidectomy is a medical emergency because it can lead to airway compression, respiratory distress, and compromised blood flow. So early detection is crucial. So seeing the sign and symptom is crucial. And symptom of neck hematoma include neck swelling or rapidly enlarging mass, neck tightness or pain, difficulty breathing or stridor, dysphagia, hoarseness of voice changes, and tachycardia or hypotension in severe case of hemorrhagic shock. So the other like performing thyrectomy or tracheostomy is not an answer, but it can be answer if you fail to alleviate the obstruction by evacuating, I mean, by opening the wound. If you fail to alleviate the obstruction, you can go for tracheostomy. It is very invasive procedure. So before trying to open the wound, you can't go to the tracheostomy. So if you failed, you can go to the tracheostomy. So intranasal oxygen application, no, because you already have airway obstruction. You should have to go to open the wound first. Uh, so inserting NG tube, no, because there is no problem with gastric. So aspirating the hematoma with needle. So at this particular patient, hematoma, you can't aspirate effectively the hematoma with needle, because when we talk about hematoma, it's there is also a clot, a clot. So clot cannot be aspirated effectively with a needle. So you will fail when if you try to aspirate the hematoma with a needle. So the correct answer would be opening the wound to evacuate the hematoma. So the third question, a victim of road traffic accident is brought to the emergency room unconscious and with a blood pressure of 80 by 60. The first step in management is A, IV ringer lactates, B, skull X-ray, C, establish adequate airway, and D, neurologic evaluation, E, abdominal tap. So please answer this question. This is very essential question. It's also, this kind of question is high yield. So please try to answer. So let's discuss. So is A answer? No, no. If you say IV ringer lactates, I will say you are wrong. You are wrong. The answer is C. C. I'm sure you see 80 by 16, and this is hypotension, this is shock, and you try to give ringer lactates. No. Do you forget ABC of life? ABC of life. ABC, always, regardless of your patient. ABC of life is the first. ABC of life. So, A, airway. B, breathing. C, circulation. D, disability. E, exposure. So, you will, in such patients, in emergency, you will have to go first for airway. This patient has definitely have circulation problems, that is blood pressure of 80 by 60, that is hypotension, that is indicative of shock. But it's not comes before airway. Airway. So establishing adequate airway would be the first, and you will go for C. So let's discuss about ABC of life. So ABC means airway. So airway, you will check for airway patency, the airway intactness. So uh, one of the best way to assess airway is talking to your patient. If the patient, for example, if you ask the patient of what's your name, and the patient says, my name is this. So that's the airway is patent. So the airway is intact. But if the patient is have difficulty to speak, so you should have to check the patient's airway patentness. So and also patients with who are unconscious, their tongue may fall back to the back, and they may swallow the tongue, and that the tongue itself may obstruct the airway. So you should have to check first that whenever, if for example, if you give for this particular patient, if you give fluid, but if the patient's airway is obstructed, you can't save your patient. The airway already kills the patient. If the obstructed airway, whatever you do next, it will kill the patient. So you should have to go A, B, C, D, and E protocol. You should have to go through that, whatever. So airway is the first. A is the first. So there is a life-threatening condition which can cause uh, the problem in airway, that is airway blockage, and also cervical spine injury in patient, for example, in patient like road traffic accidents, there may have cervical spine injury, and also there may have injuries that bone injury, and they may have uh, problem with like the injury may have their teeth may be broken, they may swallow it. So you should have to check. That is very important one. So airway. A. B. Breathing. Breathing. So you have to check the breathing. Breathing. You check the chest movement. Uh, you can. Also, Paracas, auscultate your patient's chest. You should have to see how the chest movement is. Is it symmetric? You still have to check for that. And there is a life-threatening condition which causes problem with breathing, that is tension pneumothorax, especially with road traffic accidents, pulmonary edema, and also bronchospasm. Bronchospasm, like in patient with allergic reaction, that reaction may be for drug, that may be from being sting, bee stings, and also common emergency condition which causes bronchospasm is asthma. So you should have to look uh, for the breathing problem B even before circulation. So you can check for tracheal deviation in breathing. So C is circulation. C is circulation. So you will check circulation by doing vital sign like pulse rates, blood pressure. For example, in this particular patient, the blood pressure is 60 by 80 by 60. So there is hypotension. The patient is in shock. So there is a problem in circulation. So you will also check for capillary refill. You will also check for GVP or peripheral red edema. So that is the things you should check in circulation. So life-threatening condition which causes problem in circulation is shock. It can be hypovolemic shock, like diarrhea, severe diarrhea, or like hemorrhage, or it can be obstructive shock, distributive shock, or cardiogenic shock. So D is a disability. So in disability, you will assess the neurologic examination. That's neurologic assessment. So you will ask for orientation. Is the patient oriented to time, place, or person? For example, you can ask that the patient, who am I? Oh, you are doctor, you are this nurse. So that's oriented to, or you are ask a person, a patient with someone he's well known. For example, if you may ask his father, and this is my father, so he's oriented to a person. Place, you can ask where currently that patient is in hospital, wherever. So for the time, you can ask the date, or the time, and the date or the date. So if that is orientation to time, place, and person. Also, you can go for AVPU. So is it awake? Is it uh, is not? If it's not awake, is that for awake for pain? Is awake for voice? Is that unresponsive? That is a quick way to assess the orientation and the mental status of the patient. That is AVPU. So there is, after that you can go for Glasgow Coma Scale assessment. So that's disability. Pupillary reflex will be assessed here. As a random blood sugar would be assessed here. So seizure, hypoglycemia, meningitis, intracranial hemorrhage, and infarction, intoxication. Those are the condition which is a life-threatening, which can cause disability. So exposure, you will respect the patient dignity and go for an inspection of skin, an inspection of wound if it is any, and also you will examine abdomen, especially in traumatic patients. They may have abdominal injury, so you will examine the abdomen here. So condition like hypothermia, hyperthermia, critical skin conditions such as fasciitis and urticaria is the condition you may detect in exposure. So let's go to the question. So uh, it's clear. So you will go for A, and first you go to educate airway, and then you will come to give uh, 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 fluid after airway. So the last question. A 2-year-old child presented with crampy abdominal pain and vomiting. The mother gave history that he passed blood streak stool. Examination revealed feeble pulse, tachycardia, and tender abdomen. The first step in management should be A. Inserting NG tube and observation, barium enema, C. Antihelmintic drug trial, D. Fluid and electrolyte resuscitation, E. Immediate laparotomy. So this is the same question, the same way to present as ABC of life. So this patient has a feeble pulse, feeble pulse, tachycardia. So what's those indicate? The feeble pulse and tachycardia, what does they indicate for this patient who is presented with vomiting? This is a sign of the sign of hypotension or shock. Am I right? So hypotension and shock. So the first step to go for this patient management is to stabilize first. You should have to stabilize first. Stabilize your patient. How do you stabilize? The patient is going to shock. Hypotension and sign of shock is present in this patient, and his present is vomiting. So the patient in shock, you don't go to NGTO. The patient will not go investigate before stabilizing your patient. So the best answer is here. So you will go for fluid and electrolyte resuscitation. So after stabilizing, you will go for abdominal ultrasound. By the way, this patient is, this presentation is a presentation of intussusception. It is the most common cause of intestinal obstruction in children of 2 years and below. So this patient have intussusception, and after stabilizing, you will go for abdominal ultrasound. After confirming the diagnosis, you can try enema, like enema to live. If you fail to manage with enema, you will go for surgical exploration, like laparotomy, and you will manage insertion with surgery after you fail the conservative management like enema. So fluid and electrolyte resuscitation is the most critical initial step. This ensures adequate perfusion and addresses hypovolemia and shock. So normal saline RL are used for intravenous resuscitation. So thank you very much, and please subscribe and share the video for others. Thank you very much. We will proceed to another.